Welcome. For another MCQ today, we're discussing an MCQ about peritoneal dialysis. A 63 years old woman on CCPD, continuous cycling peritoneal dialysis, which is not different from APD, apart from this will leave a day dwell. Has persistent low drain alarm despite laxatives. Effluent is clear. Fluoroscopy with intraperitoneal contrast shows pooling around the catheter with irregular filling at the tip and minimal peritoneal dispersion. What is the next best step? A. Increase fill volume and retry cycler. Alteplase intraluminal dwell. Laparoscopic omentoplexy adhesiolysis, catheter salvage, blind guide wire manipulation in clinic, immediate catheter removal and hemodialysis conversion. One of these options is the best next step. I'll give you a minute or pause the video to think about the option. The answer is C. Pericatheter stasis complex filling defect to indicate extraluminal obstruction, omental wrap or adhesion. Best managed by laparoscopy, a blunt manipulation risk, of course, perforation, and won't fix the external obstruction. Alteplase helps intraluminal clot or fibrin formation, but not wrap. Increasing volume worsens symptoms, of course, hence that's not a viable option. And removal of the PD catheter or hemodialysis, of course, is a last resort. How to differentiate between simple tip migration, omental wrap or adhesion, and intraluminal fibrin? The best test is, of course, fluoroscopy. Fluoroscopy catheter study with contrast injected through the PD catheter will give you an overview of what's going on inside. And often this is done during the troubleshooting exchange of the catheter in the IR. Right, so what's fluoroscopy finding you would see? This table shows you 3 different fluoroscopy findings you might see, which tell you what it means and what is the next step. If there is a free intraperitoneal dispersal of contrast with no pericatheter pooling, and the tip is seen away from the pelvis, migrated upward, this is isolated tip migration. Extraluminal compression is unlikely in this case. An attempt, in this case, what you could do, how to salvage the catheter, is attempt fluoroscopic guide wire manipulation over a wire repositioning in the pelvis. Before that, you need to optimize, of course, bowel preparation in order to get this procedure going smoothly, and consider temporary lower fill volume in the meantime. If recurrent, consider surgical fixation and resite. Now let's move on to the next fluoroscopy finding. If you find there is a stasis and pooling, as we've seen in this multiple choice question, there is a complex filling defect at the tip, and contrast does not disperse freely in the abdomen on the film or fluoroscopy. Sometimes a cuff or contrast around the catheter. What it means? That means extraluminal obstruction, example, omental wrap or adhesion loculation. The only way to fix this problem is laparoscopic evaluation for omentoplexy and or adhesiolysis. Now, often this done under general anesthetic. The question is, if the patient is not fit for general anesthetic, what you can do. You probably will have to try to remove the catheter over a guide wire and put another catheter. It's unlikely that the new catheter you are inserting over a guide wire will move to the previous momentum. But the risk of recurrence is still there. But sometimes you don't have another choice. If the patient is not suitable for HD, for example, usually the case, if the patient is not suitable for general anesthetic, might not be suitable for hemodialysis for various reasons, for example, heart failure, etc. Poor contrast entry, that indicate there's an intraluminal problem, either a kink or fibrin clot. Now, fibrin clot often get sorted by using heparinized dialysate first. You'll see some results, and after that you could use alteplase dwell to dissolve the completely the fibrin and clot inside the abdomen. We'll see more how to sort this flow issue in a minute. Now, there's a practical note, of course, here. If you do that, give peri-procedure antibiotic for invasive manipulation like that, and follow the local protocol in terms of antibiotic, usually gram-positive cover. You might need also gram-negative cover in high-risk patients. Always address constipation first in order to have a good result of the manipulation or salvage of the catheter. If fluoroscopy repositioning fail or dysfunction reoccurs, laparoscopic salvage has a high success and preserve PD, and to avoid switching patient to hemodialysis. So how to manage poor inflow and outflow? Let's see what the difference and how to manage the difference. In case of a poor inflow, and so there is a difficulty or longer time than usual to instill the fluid intraperitoneally. The first step is to do vigorous push-pull with 30 ml syringe or 50 ml syringe, whichever you like, for 5 minutes. And that's really need. And when I say vigorous, it's vigorous. So you'll have to use force here. Aim to free intraluminal fibrin clot. Often fibrin can come out often with this maneuver. And the second step is to use alteplase. Intraluminal dwell, 1 milligram per ml, instill 7 milligram, then 1 milligram every 15 minutes, 3 times. And that you leave that overnight. And in this case, you will have to discard the first effluent the next day when you attempt fill and drain. But avoid, of course, if there's a high risk of bleeding patient, because there is potential systemic absorption, of course, from alteplase through the intraperitoneal membrane. Step 3, repeat flush the next day. Continue a heparinized dialysate for 24 to 48 hours. If there is an improvement, of course, that will help resolve the problem completely. And the last step, of course, is fluoroscopy manipulation over a guide wire, injecting contrast to try to, assess the dispersion and see if there's a wrap or adhesion. And if there was, the diagnosis is wrap rather than intraluminal obstruction. What if there is outflow drainage problem? First step is flush with heparinized saline, 10 to 20 ml. Then heparinized dialysate, 500 per liter, 500 unit of heparin per liter. High dose laxative to treat any sigmoid loading, because this is one of the commonest cause of the catheter malfunction. Abdominal X-ray to confirm the tip of the catheter where it does sit and quantity of, fecal loading. Fluoroscopic manipulation, again, this is the last step. If there is a contrast dispersion free, then simple tip migration and just manipulation over guide wire to reposition the tip of the catheter. But if there is a pericatheter stasis, as we said earlier, then that's an omental wrap and need laparoscopic omentoplexy. I hope that helped this MCQ, and we're looking forward to meet you again with a different MCQ and more discussion.